All right, who likes endocrine emergencies? Actually, I think that these are kind of cool myself because a lot of these are kind of the actual crux of medicine. Now, I realize for a lot of EMS providers, there's probably not a lot you can do about a lot of these things, but that is actually changing quite a bit. And while most of us that are doing 911 responses may not do a whole lot about DKA in many of our patients, although I would challenge that there's probably something you can do. Any of us that are doing any long distance transports, or anybody that's on a MICU, or anybody that, again, maybe you're a 911 agency that gets tapped to transport people from a rural hospital to a tertiary care center or something like that. So you may run into these folks more than you kind of think. And you got to have an idea of what to do with them, because you can really kind of mess some stuff up if you treat them the way that almost like you feel like you should, or what you might have thought you were doing. So we got to talk about these a little bit. Also, this is a topic that's not really heavily covered, so bear with me, and hopefully this makes sense of some of the endocrine emergencies, some of which you'll see fairly often, some of which you will not. And there will be a second or possibly a third, depending on how long I run this thing for, video on the actual other endocrine emergencies. But for right now, we're mostly going to talk about diabetes. So diabetes goes back to glucose. And glucose is the thing that lets us essentially live. One of the things that lets us live. Glucose has a lot of functions. We think of it just as like the energy source, but it has a role in nucleotide development and a lot of metabolic pathways otherwise. So it's not just you need energy for it, you need it for lots of different stuff. Glucose is essential to our life as we currently understand it. In that we use glucose, we don't use a whole lot of other sugars to develop these things. So glucose metabolism is important. You can see the glucose metabolic pathway here. And again, there's a lot of stuff that goes with it. But just remember, for our standpoint, and again, this is from the ER doctor, EMS doctor, kind of 1,000-foot view, glucose is important. And it's important that we get glucose into our cells. But the concentration of glucose in our blood can make a big difference about how we're feeling, how we're surviving, and what our cells do. So how do we regulate concentration of glucose in our blood? Well, it all comes back to our friend, the pancreas. So the pancreas does a lot of stuff. It's got a lot of different glandular type functions. It just kind of chills out in the center of your belly, kind of right there. And you would think, oh, it's just sitting there and it gives you pancreatitis and makes you hurt. It helps with digestion. Interspersed among all the digestive stuff in the pancreas are the little tiny beta cells, little clumps of cells. And the beta cells are what actually produce insulin. So through a series of pathways, when your blood sugar goes up, your pancreas is triggered to release insulin from your beta cells. As insulin travels through your body, when it comes in contact with a cell, it tells the cell that it can start taking up glucose. And that's the real kicker. The insulin, what insulin does is not metabolize sugar or something like that. It does a lot of different stuff, but the primary one that we're going to kind of hit here is it says there is enough sugar, there's enough glucose in our blood. Cells go ahead and take it up and stop breaking down any fats or anything that you might have been otherwise. It's a sign to the cell that you can start taking up glucose out of the blood. That's when your blood is, when you have adequate amount of blood sugar or high blood sugar, you release insulin and it tells your cells to take it up. Take the converse effect. If your blood sugar is low, if you're not maintaining, a concentration of, 100 or something like that, say get down to 60 or 40, something like that. Your body also sends it through a series of triggers, inspires your pancreas to release from the alpha cells another hormone called glucagon. And glucagon you may have given to folks with hypoglycemia before. Literally the name says it. Glucose is gone, glucagon. When there is no glucose or low glucose floating around, glucagon is released into your bloodstream. It goes and primarily affects your liver, to some extent skeletal muscle, but also your adipose tissue, and helps to mobilize glucose stores. So it helps to start breaking down fat cells like lipolysis so that you can create additional glucose in your blood. It helps it tells your liver to start breaking down glycogen, which is your first kind of source of easily mobilized complex sugar. It tells it to start breaking that stuff down and releasing it back into the body and get some more sugar in the bloodstream. So glucagon is the signal that we're low, and all the mobilizable stores of sugar in the body we should start mobilizing. Diabetes is a problem with glucose metabolism, primarily with insulin and sensitivity to insulin or production of insulin. We've known about diabetes for a long time. Humans have known since, I think they quote the Egyptians in like 3000 BC or something like that, in saying we recognize that you start to pee a lot, you have a real sugary urine, and then these folks start to just waste away, and eventually they fall into a coma and die. And that's been the history of, essentially diabetes for all of humanity as far as humanity knows. Up until the 1850s, it wasn't really clear why this happened. People would just all of a sudden start to get sick. They would start to waste away. They would lose all their fat stores. They'd break down muscle, and then eventually they'd get sick. They'd fall into a coma and they'd die. And that was the way that it was. This was an inexorable, incurable disease, and nobody really knew why it happened. Now, in the 1850s, 1860s, we discovered insulin and what it does, and that was the first kind of kicker. But it wasn't until the 1920s that we were actually able to isolate insulin and start giving it to people to actually treat their diabetes. And they described this as a remarkable time. This picture you're looking at now is a diabetes ward in a hospital, and basically you see, every bed has a kid in it who is languishing and going into a coma and dying from DKA. And at the time, there was nothing you could do about it. All of a sudden, somebody brings in this syringe of insulin, injects it into a kid, and the kid not only wakes up, but gets better. And that was a remarkable thing. You had what was an absolutely fatal, horrible disease, and now all of a sudden, it's manageable with just one medication. And that was pretty cool. But again, that's not something that happened until really recently here, the 1920s or thereabout. Diabetes and trouble with insulin regulation is still a big deal, but it is a manageable condition at this point, at least in the United States. We're probably going to get called for one of two complications of diabetes itself, not for the diabetes per se, but for something that has happened to the patient. So what happens to diabetic patients? Well, if they have normoglycemia, if they're normal, they're not going to call us. But if their blood sugar is high, or if their blood sugar is low, is what we're going to get asked to come and attend to. Let's talk about the folks with low blood sugar first, and we'll do a case. Again, this is a grand rounds thing. So you are toned out for a 75-year-old female, not feeling well, able to talk, but feels very weak and nauseous. You arrive and find the patient sitting in a chair. She's got kind of a far-off look in her eyes. She's got a few beads of sweat on her forehead, and she's kind of pale. She gives you some sort of nonsensical answers when you ask her about stuff. Luckily, your astute crew immediately checks a fingerstick blood glucose and finds it to be low at about 45. You establish an IV, and you give the patient some D50, give her a full amp, and within about 3 or 4 minutes, the patient starts to come around. Her eyes blink a couple of times. She begins to pink up and says, "Oh, that felt terrible," and she regains her normal mental status. You do some vital signs on her. They otherwise look well. You check another blood glucose in about 10 minutes. And you say to the patient, "Okay, well, you want to go to the hospital?" And the patient says, "No, I don't want to go to the hospital. This has happened before, and I don't want to go anymore." So you say, "Okay, well, she seems alert and oriented, meets all the criteria otherwise in terms of somebody that can refuse to go." So we pack up, head back to the station. She signs the form ahead of that and get a cup of coffee and sit around for a little bit. So you get another call about 2 hours later to go to the same house. And this time it's a medic alert company telling you that the patient is not answering, but pushed her distress button. So you arrive, and you find her, in this case, in a little bit different position. She's now kind of slumped back in a chair, sweaty again, kind of pale, and doesn't look good. She, again, can't really give you any answers. You check her blood sugar, and this time it is now 35. You give her another amp of D50, and she begins to look better again. She sort of wakes up and says, "Oh, what happened?" At this point, you start asking her a few questions. "Hey, what happened with your blood sugar? Why did it run low? Did you not eat?" And she says, "No, I ate plenty. I've been eating candy ever since, you guys left previously." I'm like, well, what's going on? And she says, "Well, I don't know. My doctor's been messing with my medicine." She hands you the bag of medicine, and the list that's in it looks something like this. You find that she's on a diabetes medicine you recognize called metformin. She's on some blood pressure medicines, an aspirin, naproxen. she's got insulin crossed off as well as a blood pressure medicine, and she's got another one written down there in a different color ink than previous. Obviously, this was just added. And you say, what's this one? I don't recognize that one. And she says, the Farxiga, I think. I don't know. It's for my blood sugar. I started that last Friday. And you say, oh, all right. Well, I think we should go to the hospital. Now, let's go to the hospital. She says, are you sure? And you say, yes, absolutely, because you're an astute clinician and you remember some important stuff from the lecture that Lubbers was talking about. While in the hospital, it's notable that later on the patient continues to have low blood sugars despite eating. She gets eventually placed on a D5 and then a D10 drip for continuous glucose infusion and gets admitted for 2 days. So what's going on? What happened? Well, you got to know a little bit about the diabetes drugs. There's basically 4 different types of drugs that folks use. Now, there's a few more, but this will give you most of it. So one of the more common ones that folks use, type 2 diabetes at least, is metformin. Metformin and its analogs, the stuff that's like it, these are for people that still make insulin. So your pancreas is still putting it out. But in type 2 diabetes, the problem is not that, like type 1 diabetes, the problem is you just don't make insulin or you don't make enough insulin. In type 2 diabetes, you are probably still making insulin, but your cells have become resistant to it. They've been exposed to it at high levels for so long that they do not function when they get a concentration of insulin they would have otherwise. So metformin causes you to become more sensitive to that insulin again. It basically resensitizes you. That's the idea behind metformin. It doesn't actually cause your blood sugar to change, or it can cause your blood sugar to change, but it itself doesn't raise or lower your blood sugar. One of the other classes, that thing up on the right, is glipizide or glyburide, sulfonylureas. This class of drug, this is also for people that can make insulin. This stimulates your pancreas to release more insulin. So it's sort of like getting an insulin shot, except it relies on your pancreas to produce that insulin and then put it out there. A lot of these last for a long period of time, like 12 to 24 hours. That's why they're effective as pill form. But these essentially give you extra insulin floating around your body. There is insulin itself that we all know of, and some folks with type 2 diabetes, if they're resistant to any of the other medications, eventually get started on insulin, but primarily this is what type 1 diabetics, the folks that can't make insulin at all, this is the thing that saves their lives and allows them to continue on. There's all kinds of different formulations of insulin. The big difference between them is how long they last. So some of them are very short acting, like last an hour. Some of them are very long acting and last a day or two. As with any drug, the longer it lasts, the longer it takes to have an onset. So you'll see folks take 2 different types of insulin. One short acting to kind of smooth out, big bumps in the day, like after meals and that kind of stuff. And then a long acting one, which takes a long time to work, but also sticks with you and gives you a basal level of insulin, and then you correct the little spikes in blood sugar that happen with food or indiscretions and that kind of stuff with a shorter acting insulin. The stuff that you'll see us give in the hospital is a relatively short acting insulin that they call regular insulin. Literally, it's just called regular. And you'll see you can give that sub-Q or IV. That's what we'll typically use, what you'll probably transport somebody on if you're transporting insulin infusion. And then one last thing, these are new drugs that have come out recently. The Sglt2, I think, is the name of the Sglt2 Inhibitors. They go under trade names. This one's called Farxiga. You've probably seen a commercial for. There's another one called Invokana. There's another one that's name I can't remember. And believe me, their generic names are just a bear to say, so it's not worth me getting into it. But nonetheless, these drugs, basically what they do is when you put out sugar, when you release glucose into your kidney, they prevent your kidney from reuptaking the glucose, from sucking the glucose back in. And so it causes you to pee out all your excess glucose or a lot of your glucose. That's an interesting thing because it doesn't actually help your cells pick up, take up glucose. All it does is treat the hyperglycemia part. You pee out, sort of like diurese yourself of the glucose. But it keeps your blood sugar down, and it tends to help with some of the other stuff, and eventually you get less insulin resistant. Again, this is not going to help somebody that doesn't make any insulin. This helps to treat somebody that does make insulin but is become insensitive to it. All right, those are the drugs. You got to kind of know about those because there's a big question here, and that is, on which of these drugs is it okay to leave somebody at home if you found them to be hypoglycemic? There's really only one of them, and here's why. The thing that we're okay with doing is leaving somebody at home if they took their normal amount of insulin and then didn't eat or didn't eat enough for whatever reason. That's basically the only time when we say it's okay to stay at home. Why? What about the other ones? We fixed their blood glucose with the other ones. Why would that be a big deal? Well, for glipizide, for instance, the sulfonylureas, these last for a long time. And if the patient takes one too many pills, they can become severely hypoglycemic for a long period of time and not be able to maintain it. Likewise, if the patient has a change in their renal function or something like that, it will make those pills last for a lot longer. That drug lasts for a lot longer in their system, and then they remain hypoglycemic. So this is not a one-time event. This is something you can expect to happen again and again. So anybody that takes like a sulfonylurea definitely needs to go in and be observed. You can't just leave them at home. How about the folks that take like the Farxiga? Same thing. This is a relatively long-acting medication, and we don't know what's going to happen. They need to be observed. You can't just call this a one-time thing. But what about like metformin, which doesn't really mess with your blood sugar? Right? I mean, it messes with your blood sugar, but it doesn't directly affect your blood sugar. It just makes you use it better. The thing about that is, since it doesn't mess with your blood sugar, since it doesn't directly affect your blood sugar, if someone's just taking metformin, that means that they shouldn't get hypoglycemic. And so why would they be hypoglycemic? It's not from the drug. There must be some other reason for that. And that some other reason often is something really terrible, like sepsis, that kind of stuff. So the reason for not leaving somebody at home with metformin is because it shouldn't make you hypoglycemic. You haven't figured out why the patient is hypoglycemic, and you can't leave them in that way. So can't leave them on metformin, can't leave them on the sulfonylureas, can't leave them on the SGLT2. You can only leave somebody at home if they have insulin as the cause of their problem, and you can identify that. So to say it one more time with feeling, hypoglycemia refusals are not okay if the patient takes pills for their diabetes. Hypoglycemia refusals are only okay if the person takes insulin, and you have to follow those two rules exactly. So if the patient takes insulin but they also take pills, not okay. If the patient does not take insulin, not okay to leave them at home, even if you've treated their hypoglycemia, because that means that something else must be going on to have made them hypoglycemic, and we need to investigate that. There's a lot of stuff that'll make somebody hypoglycemic, and a lot of it is really bad. So things like insulin overdose, of course, we can sort that out, but oral hypoglycemics, renal failure, tox stuff, sepsis stuff, all this is stuff that you wouldn't want to leave somebody at home for. The only thing that is really okay is if they have normal levels of, or if they're taking their normal insulin and then they just didn't eat afterwards. That's the only time when it's really okay to leave somebody at home when they're relatively safe. One quick mention as well, starvation, you think of, well, that'll drop your blood sugar. Yeah, it does, but if you've got a functioning pancreas and functioning body otherwise, it probably shouldn't make you hypoglycemic. You should be able to maintain your blood sugar at, 50, 60, something like that. You shouldn't get profoundly hypoglycemic as a result, unless something else is going on, like you are, an alcoholic and you just don't have stores of glucose to use or something like that. So bear in mind that starvation itself really isn't a great explanation for why somebody might be hypoglycemic. Possible, but relatively uncommon in the United States anyway. Unless the problem was they took their insulin, then they're not eating. All right, how are we going to treat this? You have a choice. For the most part, we're going to supplement sugar. And for most of us, that's been for a long time an amp of D50, 50 mLs of 50% dextrose. How much sugar is in that? 25 grams in 50 ml. So if you give the whole thing, that's 25 grams. Now, the problem with that is that most people don't actually need 25 grams of glucose to wake back up, to regain normal mental status and reglycemize, I made that up, their organs. Most people would actually wake up with about 10 grams of glucose, and even that may be too much for some people. The problem when we give this big glucose load is it's more than you can process, it's more than you can use, and if you are a somewhat brittle diabetic, then it can actually screw up your sugars for the next couple of weeks. It can make it very hard to get you back on track because of this giant glucose load that all gets given in the course of about a minute or so. Additionally, if you haven't seen somebody extravasate some glucose or some dextrose into their skin, it is not pretty, especially if it's any reasonable amount. Because you don't need all that sugar, because it's somewhat hard to give D50, it's just difficult to push, and because there's some danger with it, consider the following. Could you instead use something less concentrated like D10, 10% dextrose? You have in a 250 ml bag of D10 as much glucose, as much sugar as you would get in an amp of D50. So you can do the dosing about the same. It doesn't really take that much longer for you to get in an adequate amount of D10, realistically, if you have a functioning IV. And in fact, what you can do is you don't have to give a whole 250 mLs. You could start with 100 mLs. Or what's probably a really good idea is you find somebody that's hypoglycemic, you stick them, put an IV and attach it to your bag, stick the bag on the wall, turn the roller up, let it drip in, and when the patient is awake, then you can stop it. And however much they've gotten is the dose that they needed. You don't give them, 25 grams. They didn't need 25 grams. If all they needed was 5, which would be about 50 mLs, then they wake up and, all right, that's all they needed. And if you need to give them a little bit more, you can, turn it back on. They can drip a little bit more in. That is a reasonable way to do it. D10 is a little bit easier to use. Again, the dosing is a little bit more straightforward. You just give it until they kind of wake up. You don't have to give it in boluses. And it's safe to use in kids. Additionally, if a D10 extravasates into your soft tissues, not that big a deal compared to D50 at least. So, by the way, one last thing to sort of mention, we have given glucagon in the past. Glucagon's kind of going away. You don't see it very much anymore, but some EMS services are still carrying it out there to give for folks that are hypoglycemic. And yes, glucagon works in 10 minutes, 15 minutes, something like that. And it works the same way that it does endogenously. You give somebody a shot of glucagon, their glycogen stores in their liver start to mobilize. They start to do a little bit of lipolysis. Your body senses that it's too low, and so it mobilizes all the sugar that it can, and it works. Yes, you do eventually wake back up. Your blood sugar comes back up. It works sometimes, I should say. The times when it doesn't work is when you don't have that stuff to give. So especially if you're like an alcoholic, or if you're somebody that's kind of chronically malnourished, you probably don't have a whole lot of liver glycogen to mobilize, which is the big thing that it starts to do. And waiting for it to try to mobilize any fat stores that you have is just not going to be effective. So glucagon will work in a healthy person mostly, but if you're not healthy, which many of these people are not, then it's not really going to be helpful, and it probably just wastes some time, and it's very expensive. So most of us have gone away from it. Again, if you had to pick one thing, I would recommend you pick D10, get some 250 or 500 ml bags, put the thing up there, and let it drip in until the patient wakes up, if they are hypoglycemic, if that's their big problem. Hypoglycemia that you haven't absolutely explained as the patient took too much of their normal insulin, or took their normal amount of insulin and just didn't eat afterwards. If you cannot 100% explain it with the amount of insulin they took, you got to assume that patient is septic, because that's the big sort of thing that won't always present itself real easily in these hypoglycemic patients, especially these older folks that come from nursing homes, that kind of stuff. If you can't 100% explain why exactly they are hypoglycemic, or they do anything different than you would normally expect them to, then you have to assume they're septic, and you have to investigate further with it.